Welcome to meeting number 6 of the House of Commons Standing Committee on Justice and Human Rights. Today's meeting is taking place in a hybrid format pursuant to the House Order of September 23rd, 2020. The webcast, just for members appearing virtually, will show only the person that is speaking rather than the entirety of the committee. A few rules to follow. Members and witnesses may speak in your official languages. Just ensure to select the interpretation for your language at the bottom of the screen, the language that you would like to hear. Before speaking, please do wait until I recognize you by name. Please click on the microphone icon to unmute yourself. Those in the room, your microphone will be controlled by the normal proceedings as we have done in the past. When speaking, please speak slowly and clearly. And when you're not speaking, please ensure that your microphone is on mute. With regard to the speaking list, the committee clerk and I will do the best that we can to maintain a consolidated order of speaking for all members, whether they are participating virtually or in person. You will see that I have a 1-minute card and a 30-second card for members and witnesses to let you know how much time you have remaining when it comes to the rounds of questions. And just at this time, I know that this issue had been raised in the past meetings. So I will remind members of routine motions that we've passed in our previous meetings, and I will read it out. Timing for opening remarks and questioning of witnesses, that witnesses be given 5 to 7.5 minutes at the discretion of the chair to make their opening statement, and that at the discretion of the chair, during the questioning of witnesses, in the first round, there be allotted 6 minutes for the first questioner of each party as follows: Conservative, Liberal, Bloc, NDP, and that for the second and subsequent rounds, the order and time for questioning be as follows: Conservative, 5 minutes, Liberal, 5 minutes, Bloc Québécois, 2.5 minutes, NDP, 2.5 minutes, Conservative, 5 minutes, and Liberal, 5 minutes. So I thank you for allowing me the discretion to chair this meeting in an equitable fashion, and I hope that we can continue that. Now, the reason I raise this obviously is because of the challenges we've had in the past with respect to rounds of questioning and timing, but more importantly, one of the witnesses today has asked for accommodation to be allowed for extra time to speak, where we normally give 5 minutes for witnesses. So using my discretion, I will be allowing Mr. Foley 7.5 minutes to be able to complete his remarks in the first round. So with that, I'd like to welcome our witnesses. Appearing as an individual, Julie Campbell, who is a nurse practitioner for the Provincial Care Coordination Service. We have Mr. Roger Foley, who is accompanied by his lawyer, Ken Berger. We also have the Association for Reformed Political Action Canada, appearing on their behalf, John Sikema, who is legal counsel, and Andre Suchen, who is Shuten, who is legal counsel and director of law and policy. We also have Inclusion Canada, and the person representative is Krista Carr, who is the executive vice president. So thank you all for being here today. We'll go right into questioning. We'll start with first person on my list, which is Julie Campbell. Ms. Campbell, you have 5 minutes for your remarks. Thank you very much. The floor is now yours. Please unmute yourself. Thank you.
Thank you, Madam Chair, and good morning, everyone. I'm Julie Campbell, and I speak today as a MAID assessor, provider, and from my experience coordinating, navigating, and providing leadership in this area. I want to commend this government on the thoughtful investigation that's been undertaken to understand this work and, most importantly, to understand our patients. I'm also very pleased with how inclusive ministers have been in their language, recognizing the important work of both nurse practitioners and physicians. Each month, I speak to more than 140 new patients and families, and also present to community groups. By far, the top concerns expressed to me are the lack of advance consent and the 10-day reflection period. So I'm grateful to see these addressed. I'm also grateful for the changes around witnessing requests. Patients requesting MAID should be afforded the same privacy rights as patients for any other medical procedure. Allowing care providers to sign is a positive step for this confidentiality. A specific statement allowing virtual witnessing would be beneficial. I do this work, as do most of my colleagues, because we can make a difference in reducing suffering for patients who feel that this is the right personal choice for them, given their circumstances, their values, and their experiences. I want to share with you a few key reflections that I feel are important for the implementation of this legislation at the front line. Patients in rural areas may benefit most from the option of oral self-administered MAID. This is because patients can be assessed virtually, and our knowledge of this and its safety has been tested during this pandemic. For one particular patient that received oral self-administered MAID in a remote community, their prescriber was a significant distance away, and they were monitored by local physicians and nurses who maintained communication with the prescriber. This supports both the conscience rights of clinicians and supports patients to receive access in remote areas. I believe C7 should be amended to require the presence of a regulated healthcare professional authorized to pronounce death rather than limiting the physical presence to the prescriber. In the area of Ontario where I most frequently work, I calculated the number of unique providers of MAID in the past 12 months, and I counted 49. However, 12 of the 49 assessors completed 84% of the 307 MAID provisions that year. The majority of MAID work is done by a small number of providers who have garnered expertise in this work through their experience. This highlights how we need to continue the current practice of careful, thoughtful, patient-centered assessments where an assessor reaches out to colleagues with various expertise when they feel that's needed. Should the wording require the same person to have expertise in the condition and have expertise in MAID eligibility assessment, some of our most complex patients will surely not have access due to the complexity of their condition or the number of qualified assessors in their area. This causes delays and enduring suffering where consultation when needed could maintain safeguards without compromising equity of access. It is imperative that the wording defining grievous and irremediable medical condition be left without amendment, as these criterion are understood among MAID assessors. This would maintain that the suffering could be related to either the illness, disease, or disability, or the advanced state of decline, and need not be related to both. I would also like to ensure that C7 provides the same safeguards and supports for patients with respect to advance consent. This would allow an authorized alternative signer to make the written advance consent at the direction of the patient when the patient is unable to sign and date for themselves. Lastly, I would be remiss if I did not mention that at the heart of implementing this federal legislation is collaboration with provincial governments. Inequities of access for patients exist regionally, provincially, and nationally due to these differences. Examples include coverage for oral secobarbital, scope of practice limitations that are either provincial or employer-based, support for travel to remote areas, and remuneration for nurse practitioners. The law will only provide Canadian patients choice if it can be implemented. I appreciate your time, and I thank you for your hard work.
Thank you very much, Ms. Campbell. Much appreciated. We'll now move on to Mr. Foley. As per my discretion earlier, you have 7.5 minutes to give us your remarks. Go ahead, Mr. Foley.
My name is Roger Foley. I am 45 years old. I was born with spinal cerebellar ataxia, which is a severe neurodegenerative disease. Despite my disabilities, I achieved 2 degrees at Carleton University in economics and history. I was a caregiver for my father with cancer, heart troubles, and kidney problems. I helped him live 8 years beyond his original diagnosis. He was a frontline Canadian World War II veteran. I worked at the Royal Bank of Canada as their e-business manager, being awarded several RBC Top Performer awards. I was independent and active in the community, in sports, as a musician, and as a writer. Unfortunately, my disabilities got worse over time, and now I've become totally dependent. I can no longer walk. I have very limited ability to move and great difficulty even swallowing. I need help with everything, including bowel movements, breathing, and medications. I invested a lot of time and money into making my apartment accessible, but the healthcare system denied direct funding home care to have the personal attendance I need to remain living in my own home. With the assisted dying regime in Canada, I have experienced a lack of care and assistance for which I need to live. I have been denied food and water. I have not been assisted to transfer, take my medications, and go to the bathroom. I have been abused and berated because I have disabilities and told my care needs are too much work. My life has been devalued. I have been coerced into assisted death by abuse, neglect, lack of care, and threats. For example, at a time when I was advocating for assistance to live and self directed home care, the hospital ethicists and nurses were trying to coerce me into an assisted death by threatening to charge me $1,800 per day or force discharge me without the care I need to live. I felt pressured by these staff raising assisted dying rather than relieving my suffering with dignified and compassionate care. Hospital staff failed to provide me with necessities of life. I was starved and denied water for up to 20 days. I became severely acidotic, and an expert who reviewed the case concluded a failure to provide necessities of life and gross negligence. Facing these ongoing attacks, I started researching how and why this was happening in Canada. I found out the entire assisted dying regime is all based on false propaganda, bias, conflicts of interest, blindness, and a complete abdication of the health and legal system, and the law failing to protect me. Judges that were completely biased and had conflicts of interest decided the assisted dying cases. They were supposed to be fair and impartial, but instead let down our country and failed to protect our most vulnerable. What is happening to vulnerable persons in Canada is so wrong. Assisted dying is easier to access than safe and appropriate disability supports to live. Committee members, you cannot let this happen to me and others. You have turned your back on disabled and elderly Canadians. You or your family and friends will all be in my shoes one day. You cannot let this sliding regime continue. The Truchon decision is an illegitimate decision made by a biased and compromised judge. Christine Baldwin made her decision because her father's works were used as evidence by the plaintiff's lawyer. She should have recused herself and declared her conflicts of interest. The same issues of bias, conflict of interest, and misleading Canadians about assisted dying happened in Carter, during the Lamb case, and with the Audrey Parker situation. The grave mistakes by our legal and healthcare system and the failure to protect our most vulnerable needs to end. I read an email from Jacques Truchon prior to his death revealing all he needed was 70 hours of home care per week to live. Instead, he was wrongfully assisted to die by our health and legal system. I made complaints to the United Nations and a special rapporteur completed a country visit. Her report was very critical, where she is extremely concerned about persons with disabilities being asked to consider assisted dying. I made a complaint about the lack of independence and impartiality of our courts related to assisted dying to the special rapporteur on the independence of judges. I also plan to assist with the motion to retract Trichet in Quebec, as I do not believe the judgment is legitimate and puts all persons with disabilities in grave danger. You are all highly intelligent individuals dedicated to public service. You're not so gullible, are you? Are you persuaded by propaganda, misinformation, and a lack of objectivity by decision makers? Your constituents expect you to scrutinize what has actually happened with the sliding practices of assisted dying and what you need to do to protect all citizens. Please move away from the dogma and see things how they really are. Do you want to help vulnerable people who want to give back to society and be a part of our community, like heroes such as Terry Fox? Or do you just want to be misled and have blood on your hands? My blood will be on your hands if you allow the illegitimate Truchon decision to tear down our laws. I will not survive, and there will be thousands of wrongful deaths. Help Canada be the country it should be and not what it is currently sliding towards. Thank you for your time.
Thank you very much for that, Mr. Foley. We will now move on to the Association of Reformed Political Action Canada. You have 5 minutes. Please go ahead.
Thank you. I'm glad I could be here. Just a few days ago, my wife gave birth to our daughter. And during her pretty long labor, doctors presented her with different options. So of course, new to me, but meso or oxytocin to move things along. They needed to move things along faster. Epidural, forceps, or vacuum, or C-section was discussed at one point. So in our vulnerable state, we trusted that the options the doctors presented were good options. We also wanted to know what the doctor thought was the best option, and frankly, we went with it every time. Now, medical assistance in dying, or assisted suicide, or consensual homicide, or whatever you want to call it, is not healthcare. At least it's fundamentally distinct from any other medical service. Advising someone to have a C-section or chemotherapy or pain medication is not a crime, but encouraging or inducing someone to end their own life is a crime. If MAID were simply another healthcare service, we wouldn't be here today discussing substantive amendments to the criminal code. Medical services are not regulated by the criminal code. We are wrestling here with when we as a society will permit some people to kill others. That's why this is before Parliament. The fundamental problem with this bill, as we see it, is that it fails to take this seriously enough. It's almost flippant in its treatment of the deliberate termination.
Excuse me, Mr. Chairman. The interpreters are unable to interpret because Mr. Sikema is speaking too quickly, and they do not have the text. It seems that you don't have this information. Apologies to Mr. Sikema, but I believe that we should be able to hear correctly.
Mr. Sikema, if you can please slow down a little bit in your remarks. I've stopped the time so that you don't get penalized for this. But if you could also move your microphone just a little bit above, like between your nose and your mouth, so that we don't hear that popping sound as well. You want to give it a go? Thank you.
Sure.
Go ahead.
Apologies to the translators. I meant to flip this to them a little while ago. Our current law, as amended by Bill C-14, is already interpreted to allow doctors to euthanize patients who have a decade or more of life ahead. Our current law already fails to prevent doctors from suggesting MAID without being asked, at least listing it as an option, which can send a powerful message to the sick and disabled that someone thinks their life isn't worth living. Bill C-7 not only fails to address those problems, as identified by the United Nations Special Rapporteur, among others, but it makes them worse. If Bill C-7 passes, it will be possible for a person with a serious illness to go to their doctor's office, have their doctor suggest MAID as an option for them, have the doctor's secretary pop in to witness a written request, and then to be killed as soon as a second opinion is acquired. Of course, the doctor would have to mention other options, but that's just a basic rule of informed consent. Now, that's the fast and easy track. The slow track isn't much better. For those in the ambiguous category of not reasonably foreseeable death. Bill C7 says that other options should be discussed and consultations offered, which isn't much, and one would think that such basic steps should already be there for the fast track cases. As for the 90-day waiting period, the palliative care physicians have already pointed out that it's inadequate because it often takes longer to help people manage their symptoms and to find satisfactory treatments and so on. We share that concern, but we also would point out that the 90-day waiting period is itself ambiguous, given that it begins not on the day a written request is signed and dated, as with the 10-day waiting period that would be cut, but on the day the doctor begins to assess a patient's eligibility, which could be months earlier. Now, many people seem to think further expansion of euthanasia is inevitable. This is not true. The Carter decision was very limited in scope, as the court stated at the beginning and end of its decision. This is about Ms. Taylor and persons in her position. She was near death with a known fatal illness, and the court said, we make no pronouncement on other situations where physician-assisted dying may be sought. At the end of its judgment, it bookended its judgment with those things. The lone judge who decided Truchamp failed to appreciate this and failed to recognize Parliament's objectives in limiting MAID to the end-of-life context. Now, it is the responsibility of Parliament and this committee to listen to the concerns of all parties, including disability rights advocates, palliative care physicians, and others, to be clear about its objectives, to defend them against a particular judge, and to enact more responsible policies. Thank you very much.
Thank you very much for that, Mr. Sikema. And if you can please send us your written submissions as well, or your speaking notes, it would be helpful for members. Thank you for that. We'll now move on to Inclusion Canada. That is Ms. Carr, who is the Executive Vice President. Please go ahead, Ms. Carr. You have 5 minutes.
Good morning. I'm Krista Carr, Executive Vice President of Inclusion Canada, formerly the Canadian Association for Community Living, Canada's national organization for people with intellectual disabilities and their families. Inclusion Canada has advocated for safeguards in MAID since we intervened in the Carter case. Our biggest fear has always been that having a disability would become an acceptable reason for state-provided suicide. Bill C7 is our worst nightmare. Inclusion Canada stands united with all national disabled persons organizations in calling for MAID to be restricted to the end of life. The disability community is appalled that Bill C7 would allow people with a disability to have their lives ended when they are suffering but not dying. This is not how we respond to the suffering of any other group of Canadians, much less any other charter-protected group. We're told this abrupt pace of passage through Parliament has been set by the Quebec Superior Court, yet amending the criminal code to satisfy a Superior Court decision appears unprecedented. We're told Canadians want this, yet every national disability organization is opposed. If Canadians supported assisted suicide for being Indigenous or a member of the LGBTQ2S+ citizens, for example, who are suffering as a result of being Indigenous or because of their gender identity, we would not be here today. Canadians recognize suicide is more prevalent amongst those who experience systemic racism or societal devaluation. Thus, prevention is a necessity, and every life lost is a tragedy. Why is it not just as great a tragedy for an Indigenous person with a disability or someone with any other identity who has a disability? And I hope you will hear from Indigenous organizations as part of this committee. The human rights of a charter-protected group must never be a matter of public opinion. Equating assisted suicide to an equality right is a moral affront. There are 3 points I'd like to cover. First, why us? As no other charter-protected Canadian life is being put at risk by this bill, there is only one answer to this question. The lives of Canadians with disabilities are not of equal value. Language and perceptions are powerful. Including disability as a condition warranting assisted suicide equates to declaring some lives as not worth living, a historically horrific premise with consequences that should terrify us all and clearly terrifies the disability community and their families. Second, people with an intellectual disability and their families are in a constant struggle for inclusion, a universal human right not yet realized in Canada. When people with intellectual disabilities suffer Because of their pervasive exclusion and marginalization, families now fear their family members will be encouraged to end their lives. Rather than address their suffering as we do for every other Canadian who tries to end their suffering through suicide, their lives are now judged as not worth saving. To be clear, an inclusive life remains elusive for the majority of adults with intellectual disabilities. There is no right to adequate supports in Canada. 75% of adults with an intellectual disability are unemployed. They are 4 times more likely to be living in poverty, 4 times more likely to experience violence, and a staggering amount of people with an intellectual disability remain housed in institutions and long-term care facilities. Canada is failing its commitments under the UN CRPD to uphold the rights and inherent dignity of all people with disabilities. Persons with disabilities in Canada suffer an inadequate patchwork of supports with extensive wait lists for services. A state-sanctioned death is not the solution. Third and lastly, until now, MAID has been restricted to end of life. The end of life requirement was the only safeguard whereby disability was not the sole criterion. With having a disability itself under Bill C-7 as the justification for the termination of life, the very essence of the Charter of Rights and Freedoms would be shattered. Discrimination on the basis of disability would once again be entrenched in Canadian law. People with disabilities have been historically devalued and marginalized in Canada, and that remains to be sufficiently remedied. Bill C-7 further devalues the lives of people with disabilities and fundamentally changes MAID from physician-assisted dying near the end of life to physician-assisted suicide on the basis of disabilities. The lives of people with disabilities are as necessary to the integrity of the human family as any other dimension of humanity, and this threat to the lives of people with disabilities is a threat to us all. We urge the committee to seek an amendment to MAID to sustain MAID as available only to those who are dying and unequivocally restrict anyone with a disability from having their life ended unless their natural death is imminent. Thank you.
Thanks very much for that, Ms. Carr. And thank you to the witnesses. We'll now move on to our first round of questions. So the first round of questions will be 6 minutes each. Mr. Moore, please go ahead. You have 6 minutes. Your time is starting now.
Thank you, Madam Chair, and thank you to all of our witnesses. You all bring something different to this discussion, and really appreciate your very informed presentation. And you know, it concerns me when we're dealing with something that's literally life or death. The dramatically reduced time that we're dealing with this important issue. We're only taking 4 days of meetings to discuss this. Parties are only going to have about 1 round of questions to ask you important questions. And when I hear Inclusion Canada, an organization that works with those in the persons with disabilities community from coast to coast, describe this as a worst nightmare, I really truly believe that we need to have more discussion on this. The government would have us believe that this is a open and shut case, that there's a great deal of unanimity amongst doctors. But I'm going to ask my first question to Krista Carr with Inclusion Canada. There's a group called Physicians Together for Vulnerable Persons. We received a letter from them, and I know your organization works deeply with vulnerable persons. It was signed by 800 medical doctors throughout our country, from every province. These are people that are working with people who are vulnerable. And I know the position of Inclusion Canada was that the Court of Appeal decision should have been appealed even to the Supreme Court. That happens to be the position as well of the Conservative Party, that this decision should have been appealed. But this bill goes far beyond even responding to the Quebec decision. And my question to you, if you could answer it quickly, is are you, as Inclusion Canada, of the opinion that this bill needs more review to analyze the impacts, even that we heard about today, on safeguards for the persons with disabilities community?
Thanks, MP Moore. Yes, we are, of course, of that opinion, and we also we feel very strongly that, you know, the only way to make this bill not discriminatory is to keep it to the end of life. Anybody who is at end of life and is suffering intolerably has access. When you make it based on the grounds open it up and make it based on the grounds of things like disability, who is already a very vulnerable population in our society today, and experiences a tremendous amount of systemic ableism in the healthcare system already. And we've seen that pervasively throughout the COVID-19 pandemic in everything from triage protocols, deprioritizing their lives, and the list goes on. We're in a very dangerous slippery slope. And I think we have to stop, hit the pause button, and really, really focus particularly on a consultation with the disability community. We are speaking, we are trying to speak, we are united, but our voices are getting drowned out by people who do not experience the systemic marginalization, the poverty, and the very difficult lack of supports and life circumstances that people with disabilities experience that lead them into situations where MAID is either promoted to them or they feel like it's their only option. But
Thank you. Thank you for that. That brings me to my next question. The promotion or the choice that people are being dealt. Mr. Foley, thank you so much for your testimony today. You certainly bring a perspective that we have not heard at this committee. I think we should hear more of your perspective with the government expanding access to assisted dying in Canada. I heard the recordings that you had where a doctor was pressuring you into MAID and was saying that the per diem rate to stay at the hospital was $1,500 or so dollars. And you mentioned the contributions of persons with disability, including Terry Fox, and how much even that you're doing today by bringing this, standing up for vulnerable people at this committee for this meeting. My question to you is, do you feel there should be greater protections in this legislation that we have before us for vulnerable Canadians so they're not pushed, as you were, towards medically assisted death?
Mr. Moore, I'm going to answer that on behalf of Mr. Foley. Absolutely, there needs to be very robust protections here because people with disability can be easily exploited. They're subject to abuse, and they could be at high risk of being wrongfully assisted to die. The other issue is that such individuals, the disabled, all they really need is the care and support and good care. And 99.9% of the time, their grievous and irremediable suffering will be gone. You do that, you solve the problem. Then for the remaining 0.1% where you can't relieve the suffering, then let's take a look at this. This is a subjective conclusion based on the individual.
Thank you.
There is a...
Thank you, Mr. Berger. My apologies. We're out of time for Mr. Moore. We're going to move on to Mr. Virani for 6 minutes. Go ahead, Mr. Virani. Your time starts now.
Thank you very much. And thank you to all of the witnesses for their important testimony today. I want to start with Ms. Campbell. Ms. Campbell, we've heard today and we've heard in previous testimony about instances of influence, potential coercion. You yourself are a nurse in the middle of this milieu. Can you tell me, is the appropriate step when such instances are raised to raise a complaint to both professional regulatory bodies and or the police if such influence is being asserted so that it can be investigated? And if that is the proper course, can you tell me what is your knowledge of any complaints resulting in actual prosecutions against nurses or physicians, if you're able to answer that? Thank you.
Sure, thank you for the question. The answer is no, there hasn't been any that I'm aware of move forward. And certainly there are those safeguards and steps in place for patients or families to raise those concerns. So that exists. And I believe there's a very big difference in our language between saying that something is available and saying that someone then warrants or needs or should have a certain procedure just because it's available. That's very individual. And the same thing, to advise of alternatives is not the same as encouraging. So I think they're very different in how we word those.
And in your experience, Ms. Campbell, is active encouragement and pressure being put upon individuals to pursue medical assistance in dying?
No, in fact, what I find is more people that come and say, I wish I knew that those were my options earlier. Nobody mentioned it to me. So I think as important as it is to, I think it's very important not to encourage anyone to pursue a particular option, but it's equally important that all patients know all of their options and get to decide for themselves which option is right for them.
If I could turn to Ms. Carr. Ms. Carr, I respect the work that you do and all of the groups that you represent in your interventions in previous court cases, et cetera. I'm just struck by something that when I look back at the Truchon decision, the two individuals in that case, Mr. Truchon and Madame Gladue, were themselves persons with disabilities. They themselves brought forward the claims that they put in front of that judge in the Quebec Superior Court. What the judge found, and I looked back at it while you were testifying, and I was reading from about paragraph 681 and following all the way to paragraph 690. It's a long decision. But the judge addressed head on the issue that you're raising, and you raised the equality rights of these individuals, and you compared sort of indigeneity or people who experience racism, et cetera, with persons with disability. Those are important rights. This is an area that I practiced in prior to coming to Parliament. But what the court found is that when you look at it from an equality rights analysis, in fact, the Section 7 and the Section 15 rights of Monsieur Truchon and Madame Gladue were being violated by virtue of their inability to pursue MAID because it was restricted to the end of life. So they did do that analysis, but the conclusions are vastly different than what you indicated in your testimony. So I'm just wondering if you could comment to us on that portion of her decision, because what she clearly said is that by seeking to counter only one of the stereotypes, I'm reading from paragraph 681, by seeking to counter only one of the stereotypes that the disabled face, vulnerability, the challenge provision perhaps perpetuates another probably more pernicious stereotype, the inability to consent fully to medical assistance in dying. And what she explained is that we need to empower and give autonomy to persons with disability, the same autonomy that is granted to people without a disability. So I've lost you on my screen. I'm sorry, there you are. If you could perhaps comment on that point, Ms. Carr. Thank you.
Yes, thank you for the question. First of all, I want to point out that Jean Truchon was presenting himself for a medically assisted death because he couldn't get a good life. And that was very clear in the proceedings. He was forced to live in an institution. He didn't want to live there. His life was not good. He tried, there were multiple attempts for him to live other places and have a better life. And nobody seemed to be able to get him out of that place. And that's how he ended up there in the first place. And that's the thing we lose quite a bit when we talk about the Truchon decision. The second thing is about the rights piece. So we talk about this being all about autonomy. It's all about individual choice and decision. But it is a balance of autonomy rights and equality rights. And Section 1 of the Charter, that's what we have it for. We say that we can violate autonomy rights if it's for the public good. And we have to keep in mind that for people with a disability, this is not a choice. Every day of their life, the lives that they are forced to live because of inadequate supports, poverty, and society depriving them of inclusion causes their suffering. And that suffering can be remedied through many, many, many other means. But because we don't respond and governments don't provide the supports and communities and society don't include people, then they're forced into situations where they feel they have no choice. Sure, they're presented with options. For example, the bill says we need to let people know what services are available. But letting people know what's available doesn't get them services and supports, doesn't get them off wait lists, doesn't get them out of institutions. It doesn't make their life better. Until we're committed to making sure that everybody has the opportunity, an equal opportunity to live a good life, then medically assisted death on the basis of disability is not the solution.
Thank you very much. Thank you, Mr. Virani. Monsieur Thériault, voulez-vous commencer pour votre...
Would you like to comment? You have 6 minutes. Yes, I'd like to thank all of the witnesses for their testimony this morning. Mr. Foley, your testimony was both touching and troubling. In the debate such as the one before us, we must absolutely not confuse concepts. The reasonably foreseeable death criterion, as far as practitioners are concerned, was something that was causing problems. In Quebec since 2015, terminal end-of-life care, in other words, a palliative situation, could lead to the emergence of a patient's asking for medical assistance in dying. Palliative care, which should still be improved, it's one thing to demand better conditions for patients. It's something entirely different to substitute oneself for their own freedom of choice. We must not be paternalistic. And an individual's dignity is based not on physical dignity, not on psychological autonomy. That's not cognitive capacity. Those promote autonomy. But a person's dignity is based on the respect of their moral independence. And their moral autonomy is based on having their free choice respected, their ability to determine for themselves in a biomedical situation. This means free and informed consent. Mr. Foley was not in a free and informed consent situation, and he is before the courts. I'm going to stop there. I don't want to comment on that situation. But that's not what things are about this morning. This morning, the issue is to be able to enable individuals who are in an irreversible dying process, because it's already underway in a terminal situation, to have a choice. In the case of others, such as Mrs. Gladue, who has not yet exercised her right to die with dignity, was saying in an interview that she was already relieved and she was suffering a little bit less because now she had the choice that had been removed from her. So we must not confuse a suicidal state or the societal combat against suicide, because that's irreversible, and a point at which a human being who has experienced a full and complete life, such as a case of, for example, what Mr. Foley was talking about, he's demonstrated that he has had a full and complete life. Now he's more limited somewhat. It is up to the human being, up to the patient, only the patient. The patient is the norm. It's up to the patient to decide. Mrs. Carr, you are against this principle?
We're against the systemic discrimination of allowing people to be euthanized or put to death because on the basis of their disability, when they can't get the support they need to live well within their communities. And so they may very well find themselves in the system, in the medical system, and by virtue, and the suffering that they're experiencing is being caused by the lives that they are living. And they can't get the support they need to live the lives that they want to live. And the medical system alone cannot get those supports for them. So having access to ending your life, as opposed to being able to live a good life. I mean, if somebody is already dying, and we already have that in the legislation, if somebody is already suffering intolerably and their death is reasonably foreseeable, they can access MAID anyway. Anyone can do that. What we're doing with Track 2 or Bill C7 is we're singling out one particular charter protected group of Canadians and saying, boy, it must be terrible to live your life And we think it's so terrible that we're going to assist you to end it when you show up in the system and you need support to live. And I know we're not necessarily doing it intentionally, but that is what happens. And we have examples that I'm happy to send of case after case after case of this very exact same
Madame
thing.
Carr, excusez-moi.
Mrs. Carr, maybe it is not up to me or to you, or only the patient itself or herself should define what is tolerable for that person. That is respecting the person, their dignity. Of course, we want to have people to have the best care possible, but in the end, you will agree with me that only the patient can decide what is tolerable or not, and to have freedom of choice.
20 seconds, Ms. Carr.
Having respect for people is trying to make their lives tolerable and bearable the same way we do for any other person who is not identified as having a disability who tries to commit suicide or wants to end their life. We intervene in every possible way we can to help make their lives better.
Thank you, Ms. Carr. Merci, Monsieur Thériault.
Thank you, Mr. Thériault.
Mr. Garrison, you have 6 minutes. Please go ahead.
Thank you very much, Madam Chair. And I want to thank all the witnesses who appeared before committee today, and also to thank members of the disability community and their advocates for their passionate presentations both today and away from this committee table. I guess I would say that I do believe we need to hear more on these issues, and that's why as I've said before, am disappointed we have not yet started the statutory review of medical assistance in dying, which I believe deals with some of these larger issues that are being raised today. The court decision took reasonable foreseeability off the table, whether we like that or not, and whether it had been appealed or not, I believe it would be likely to be upheld in higher courts. So what we're left with is an attempt to deal with that decision and to deal with some other urgent issues in medical assistance in dying. So I want to turn back to Ms. Campbell, who raised those issues, which I've heard a lot about in my constituency. And that's the issues of relieving suffering caused by the 10-day waiting period, and also by the inability to waive final consent. And I believe those are urgent things we must deal with that justify a speedy consideration of C7. So could you say a few more words about those issues, Ms. Campbell?
Thank you for the question. Patients that call me are not calling me at the first thought that they've ever considered medical assistance in dying. These are people who have really considered, they've often been in the healthcare system for a long time, they've been presented with many options, and they are knowledgeable people who have evaluated their own values, their own experiences. Many of them have discussed this thoroughly with their family before they've called, and they're not jumping at making that phone call, but they are making the call to determine what other options may be available to them so that they can best consider those. So I think they're frustrated with then having to wait another 10 days once they've come to that decision. And advanced consent is the one that I actually hear the most about. And I hear that more from patients who are really at risk of losing their capacity, such as the Audrey Parker case. Or I also hear it from many community groups who are really concerned that should they be in that position in the future, that those rights would not be available to them.
Thank you. In testimony from Dr. Dawes, who's also a MAID assessor and provider, she said to the committee and also in a written brief that she didn't meet anyone who wanted to commit suicide. She didn't meet anyone who wanted to die. She met people who wanted to deal with what nature was presenting them in a dignified manner. Can you comment on your experience with this?
Yeah, I would say my experiences are very similar. If I could give my patients anything, I would give them life. But life isn't necessarily the options that they're being presented with. So when they look at their different options, they're considering MAID as one of those options. but many of them are choosing between very hard choices. And my wish for them to be better certainly doesn't make that so, although I would do everything I could to assist with that.
And I know time is very short, but can you give us a brief comment on the role of witnesses, since we sometimes seem to assume that witnesses are judging whether the assessment has been correct, when in fact they're judging what the identity and the signatures on documents, I believe. Can you tell me if I'm correct in that?
You are. The witnesses generally are, they are sometimes independent volunteers with no medical contact whatsoever, just simply noting that that person signed that form, or that person directed a third person to sign on their behalf when they're not able.
Thank you very much, Madam Chair. In the interest of time, I'll conclude my question there.
Thank you very much for that, Mr. Garrison. You still had a minute and a half, but that is okay. So in that case, we'll move on to our second round of questions with 5 minutes, starting with Mr. Cooper. Go ahead, Mr. Cooper.
Great. Thank you very much, Madam Chair, and thank you to the witnesses for your very helpful testimony. I want to direct my first question to Mr. Sikkema or Mr. Schouten, as well as Mr. Berger. In the Supreme Court Carter decision, the court adopted the pronouncement of the trial judge, wherein the trial judge stated that risks associated with physician-assisted death, quote, can be identified and very substantially minimized through a carefully designed system that imposes strict limits. Now, we have heard some fairly compelling testimony about how vulnerable persons could be put at risk as a result of the removal of important safeguards passed in Bill C-14. Can you speak to any charter issues that you see in that context, Mr. Sikkema, Mr. Schouten, or Mr. Berger?
Perhaps I could respond to that very intuitive question. The charter also involves the right to life and security of the person, which seems to have been forgotten, and clearly the trial judge in the Truchon case, in my opinion, did not pay sufficient attention to that. The fact is that there, as you mentioned, there needs to be strict limits. Well, the problem is, as I was mentioning earlier, this is a subjective decision based on potential influence and based on coercion. All we have here is government questionnaires with leading questions. And with respect to anyone who's making a decision, the MAID assessors, there's the risk of confirmatory bias. So if they believe that assisted dying is right, they are more likely to not see issues with capacity, not see issues with the consent, not see coercion, because what they think that they're doing is something humane and right. So there needs to be robust, strict protections here, including not only substantive protections of only doing it near life, but having committees decide this, not a physician who's actually doing the act, because they're more likely to find that what they're actually doing is correct. So there needs to be substantive safeguards and procedural safeguards that are strict and rigid. Thank you.
Thank you for that, Mr. Sikkema. I'll give you a chance to weigh in on my question as well.
Thank you. Adding to what Mr. Berger said, I think the expert report of Dr. Madeline Lee in the Lamb case is quite instructive on this. She actually developed and she oversees the MAID program at the University Health Network in Toronto. And in her expert report, she describes the case of a woman who had bone cancer and depression. She was assessed by two experienced MAID providers, not by her oncologist and a psychiatrist, and they approved her for MAID. She changed her mind during the 10-day waiting period, and decided to do palliative care instead. Later, during another crisis, she requests MAID again, and her MAID providers decided that, again, that she's eligible, go ahead. They apparently had no concerns about her ambivalence. And then she ended up changing her mind again during the next waiting period. We talked about the waiting period not mattering as a protection. I mean, this is right there in an expert report by someone who designed the system in Toronto. It's quite remarkable. I recommend looking at that expert report.
And any comments on charter issues specifically?
Yeah,
go ahead. Yeah.
My colleague Andre's on the call. He's written a paper about just how practically this means the criminal law does not protect your life as strongly. I'm speaking for him here, but as strongly where you have a disability or a chronic illness, because your death wouldn't be investigated to the same extent. We talked about equality earlier on this call. I can't get MAID because I'm not disabled. So the disability equality angle has kind of two sides there, and I think that's important to recognize. That Section 15, I think, goes the other way too.
Okay, Mr. Berger.
Mr. Cooper, you literally have 5 minutes. Sorry about that,
okay,
Mr. Cooper.
No problem.
Thank
you, Madam Chair.
Thank you. We'll move on now to Mr. Zaberi for however much time it takes us till we have to get through this panel. Thank you. Go ahead, Mr. Zaberi.
I want to thank all the witnesses for joining us today. I wanted to put this question to Mr. Foley and others who want to contribute to this. But essentially, I know that many of you are advocating against opening up MAID to non-reasonably foreseeable deaths. I appreciate that. It's something we're considering. However, let's say I want you to open up and let's say for a moment that we actually do consider non-reasonably foreseeable deaths. In your opinion, how do we protect those with disabilities from your vantage point and vulnerable persons? Mr. Foley and others who would like to contribute.
Madam Chair, I don't believe it's possible to protect the disabled if you open it up. There's already cases with the existing law demonstrating that the disability community is in danger, and this is just further going to exacerbate that. So there is no way of, in my respectful submission, there is no way without limiting it to close to death. There is no way of limiting it.
Thank you. So just very quickly, I have another minute. Would anybody want to actually flesh out how we could, if we open it up, how could we protect disabled persons? I feel this is really important given what we're studying.
The current safeguards are already failing under Bill C-14. Taking away those safeguards, there's absolutely no way to protect vulnerable and disabled persons from a wrongful assisted death. I'm disabled, and I know that if you pass Bill C-7, I won't survive, and there'll be thousands of wrongful deaths, and you'll see the numbers pile up. So I urge you to please do not allow this regime to continue to slide.
Thank you. Thank you very much, Mr. Zaberi. We are a little bit out of time. My understanding is that there was a little bit of interpretation that was interrupted, Mr. Zaberi's, but I think it has resumed. If anybody has any issues with respect to that interpretation, please do reach out to the clerk. We'll get you that text. But I'd like to take this moment now to thank all of the witnesses who appeared today for your testimony. Thank you very much. We will be now suspending to move on to our second panel. Thank you again for being here today. welcome you to our second panel. Just a quick go over of the rules before we start. You can speak in your official language. Just ensure that you have the proper interpretation language selected at the bottom of the screen. When you're speaking, please speak slowly and clearly. And when you're not speaking, your microphone should be on mute. With respect to the speaking list, Mr. Clerk and I will do our best to ensure that we're maintaining that speakers list. I have a 1-minute card and a 30-second card that will allow us to keep time for the questioning. And at this time, then I'd like to welcome our witnesses. We have appearing before us today as an individual, Dr. Catherine Frazee, Dr. Ewan Gallagher, and then we have the Organization of Council of Canadians with Disabilities. Appearing on their behalf is Dr. Heidi Jans and Taylor Hyatt. And then we also have Living with Dignity, and appearing for them is Michelle Rakiko. And I understand that Ewan Gallagher, who was having difficulties getting in, is now in the virtual room. So welcome. Excited to have all of you. I understand that some of the witnesses have audio recordings, so we'll go ahead and start and try to provide as much as possible. Dr. Catherine Frazee, please go ahead. You're our first opening witness. You have 5 minutes. Please go ahead.
I speak today from Mi'kmaq, the ancestral and unceded territory of the Mi'kmaq people. I am a settler here, bound by treaties of peace and friendship, and mindful that we are, all of us, treaty people. Madam Chair, I am sorry for any discomfort that my words may trigger, but with so little time, I must speak frankly and without reserve. Bill C-7 begs the question, why us? Why only us? Why only people whose bodies are altered or painful or in decline? Why not everyone who lives outside the margins of a decent life? Everyone who resorts to an overdose, a high bridge, a shotgun carried out into the woods? Why not everyone who decides that their quality of life is in the ditch? Surely the answer rises up in all of our throats. That's not who we are. We dial 911. We pull you back from the ledge. And yes, we restrain you in your moment of crisis. Autonomy be damned. We will get to the heart of the problem that drove you out into the woods, and we will beckon you back toward a life that is bearable. Unless your suffering is medical or disability related, then and only then there will be a special pathway to assisted death. Universality is the bedrock of our healthcare commitments. Why then does Bill C-7 depart so radically, dropping the threshold for MAID for one social group known to bear the trauma of suicide at catastrophic rates, but not for others who suffer and die before their time? What is it about disability that makes this okay? Why such breathless confidence that Bill C-7 will bring no harm to disability communities? Honestly, I do not know. But as we marshal our evidence for the legal challenges that will follow if this bill is passed, this is what we hear in reply. Some say that the suffering of a disabling medical condition is unlike other suffering, somehow more cruel than the overwhelming pain of any healthy, non-disabled person who turns to premature death by suicide. But there is no evidence to support this. Some say that the suffering of disability defies all hope as it did, they claim, for Jean Toussaint. But the deprivations of institutional life that choked out his will to live were not an inevitable consequence of disability. Did we learn nothing from Archie Rowland's harrowing struggle and his final cri de coeur before assisted death? It's not the ALS that's killing me, he said. Some say that the suffering of disabling conditions falls in the domain of medicine, but the agonizing quest of Sean Taggart teaches us otherwise. Let's not forget he called the bureaucratic denials of needed care a death sentence, just days before his assisted death. Some will fall back on the mantra of choice. They say that not everyone wants to live that way. But not everyone wants to live with the indignities of poverty either. No one wants to live under threat of racial or gendered or colonial violence. No one wants to live hungry, incarcerated, abject, or alone. Madam Chair, will our lawmakers carve out other shortcuts to assisted death for those who do live in such conditions? Or will you rise to the defense of human rights? If the latter, I respectfully urge that you start with us, for our equality is right now on the line. Thank you.
Thank you very much, Dr. Frazee, for your testimony. We'll now go on to Dr. Edwin Gallagher. Please go ahead.
Madam Chair, honorable members of the committee, I speak to you as an academic physician scientist, a critical care specialist who frequently provides end-of-life care, the father of a child with physical disabilities, and as a very concerned Canadian citizen. I wish to address you specifically on the ethics of moral objection to euthanasia. The first patient I was ever asked to examine in medical school was a young man with profound disability from primary progressive multiple sclerosis. I will call him Nathan, though this is not his real name. Nathan was paralyzed from the neck down, bedbound, and blind. As I interviewed him, he began to speak of his experience as a person living with serious disability. He spoke especially of the deep loneliness that he felt, the isolation from the rest of the world, the absence of meaningful friendship. His pain was primarily not that of physical suffering, but of deep despair of ever enjoying meaningful human contact or relational intimacy. All these years later, I wonder if Nathan would have considered seeking a doctor's help to commit suicide. I invite each of you to imagine that you are the one to fulfill that wish for someone like him. You place the intravenous line. You inject the sedation to put him to sleep. You inject the paralytic agent to halt his breathing. Within minutes, his heart stops and he is gone. His loneliness and hopelessness are ended, and so is he. We must all agree that this patient's loneliness and despair are tragic. We all agree that he deserves the very highest level of care and compassion, that we must work to uphold his dignity and his quality of life. Yet with respect to the ethics of causing his death, many like myself find a variety of important reasons to object to participating in such an act. First, we argue that euthanasia devalues the patient by treating them as a means to an end. In order to make Nathan's suffering go away, we would make him go away. We intentionally target and end his person in order to resolve his loneliness and despair. In doing so, we are treating him, his person, as a means to an end, rather than as an end in himself. True respect for the intrinsic and incalculable worth of persons requires that they always be treated as ends in themselves. We do not destroy that which we regard as profoundly and intrinsically valuable. Second, since respect for persons is the moral foundation of the duty to respect autonomy, in treating persons as means to ends, we undermine the very basis for respecting their autonomy. If persons can be intentionally rendered non-persons, then what makes their autonomy inviolable? Third, in participating in the patient's act of suicide and causing his death, we are implicitly declaring that we agree that his life is not worth living. We are affirming his perception that his existence is no longer desirable, that we are supportive of his non-existence. Nathan's loneliness and despair highlights the way that even while we may be autonomous, we are also deeply dependent on others for affirmation and value. Bill C-7 declares that an entire class of people, those with physical disabilities, are potentially appropriate for suicide, that their lives are potentially not worth living. Indeed, were it not for their disability, we would not be willing to end them. I cannot imagine a more degrading and discriminatory message for our society to communicate to our fellow citizens living with disabilities. Now, reasonable people may disagree over the ethics of euthanasia, yet given the concerns raised here, it is understandable and eminently reasonable that many physicians and nurses object to participate in the provision of euthanasia in general and to those with disabilities in particular. Contrary to the claims of some, objecting to euthanasia is not motivated by selfish concern for personal moral sensibilities, but rather by a profound moral concern to uphold the value of the patient and to maintain high quality medical care. Moreover, the Canadian experience has shown that protecting conscience presents no obstruction to patient access. Bill C-7 should be modified to clearly ensure that Canadians' fundamental freedoms of conscience are upheld and supported in ways that Bill C-14 failed to accomplish. Finally, I implore you to ensure that the law requires, if this law is passed, that it requires the physical, social, psychological, existential, and spiritual needs of patients like Nathan have been thoroughly and systematically addressed before they are considered to be eligible for euthanasia. He and others like him deserve the very best opportunity for living before they conclude that their existence is pointless and should be ended. Thank you for your consideration.
Thank you very much for that, Dr. Gallagher. We'll now move on to the Council for Canadians with Disabilities, who have asked for an extra amount of time, and given my discretion, I've allowed them 7.5 minutes between the two witnesses that are appearing. Ms. Jantz will be making her opening statement through an audio file to be played. It'll be text to speech, and so she will be taking 6.5 minutes. So go ahead, Ms. Jantz. Thank you very much.
Chair. It's Dr. Jantz, please.
Dr. Jantz, my apologies. Go ahead, Dr. Jantz.
Justice Committee, I appear before you as the chair of the Ending of Life Ethics Committee of the Council of Canadians with Disabilities, a national organization with a mandate to preserve and promote the human rights of people with disabilities. I feel compelled to spend a few precious moments of my allotted time to register my concern, indeed, my alarm, at the breakneck speed at which this committee is operating. This committee has been convened to study the potential impacts of expanding eligibility for medical aid in dying to include ill and disabled people who are not dying. Those in charge of this committee are very aggressively rushing the important and complex work of the committee. All of this is happening in the middle of a global pandemic, when our focus as a country has been on taking measures to protect the lives of our most vulnerable citizens. At best, this is extremely ironic. At worst, it is hypocritical, irresponsible, and extremely unethical. As someone who relies on assistive and augmentative communication, I had to request additional time beyond the 2.5 minutes allotted for my testimony. This incident illustrates the reality of systemic ableism. Within a society designed by and for typically functioning people, ableism causes the support needs of people with disabilities to be viewed as excessive and unsustainable. This has enormous and very dangerous implications for the expansion of MAID. Disability scholar, Veronica Schwiena-Ard, defines ableism as ideas, practices, institutions and social relations that presume able-bodiedness, and by so doing, construct persons with disabilities as marginalized, and largely invisible others. Like racism and sexism, ableism classifies entire groups of people as less than, and perpetuates harmful stereotypes, misconceptions, and generalizations about people with disabilities. Unlike racism or sexism, however, ableism remains, in the words of Canadian disability scholar, Gregor Wolbring, one of the most societally entrenched and accepted isms. People with disabilities are at a higher risk of suicide due to systemic and internalized ableism. Yet they face substantial barriers when trying to access suicide prevention services. Medical professionals overlook typical sources of stress, problems arising from relationship breakdowns, depression, and isolation are wrongly attributed to disability. The removal of reasonably foreseeable natural death as a limiting eligibility criterion for the provision of MAID will result in people with disabilities seeking MAID as an ultimate capitulation to a lifetime of ableist oppression. In a truly just and progressive society, suicide prevention measures should be applied equally to all people. More and more Canadians with disabilities find themselves in extreme financial distress as the pandemic drives up costs while already meager provincial income support remains stagnant. What's more, some provinces have recently been publicly musing about reducing, or altogether scrapping, their income support programs for people with disabilities. Recent news reports indicate that some people with disabilities living in poverty are being driven to end their lives through MAID, because they lack the means to survive. Physicians report that patients with disabilities are requesting MAID upon learning that the wait time for accessible housing with the supports they require is 10 years or more. Given the demonstrated ongoing prevalence of ableism in Canada, the Council of Canadians with Disabilities is recommending the following amendments to Bill C-7 in hopes of limiting the bill's capacity to weaponize ableism in this country. 1. Receipt of adequate housing, income support, palliative care and home-based services should be prerequisite eligibility requirements for MAID. The onus for providing these supports at the level required must fall on governments. A person with disabilities should never bear the burden of trying to lobby for adequate supports. 2. Refer to the Supreme Court of Canada, by way of constitutional reference, Bill C-14's existing protections limiting MAID to cases where a person's natural death is reasonably foreseeable. 3. Any changes to Canada's MAID law must meaningfully respond to last year's end of mission statement of the United Nations Special Rapporteur on the Rights of Persons with Disabilities, wherein Ms. Catalina Devandas Aguilar communicated her serious concerns about significant shortcomings in the way all levels of Canadian government respect, protect and fulfill the rights of persons with disabilities. Specifically, she noted that there was a lack of protocol to demonstrate that persons with disabilities have been provided with viable alternatives when eligible for assistive dying and that she had received worrisome claims about persons with disabilities in institutions being pressured to seek medical assistance in dying, and practitioners not formally reporting cases involving persons with disabilities. 4. Canada's amended medical assistance in dying law should follow the judicial directive of the SCC in Carter, which required a carefully designed system that imposes stringent limits that are scrupulously monitored and enforced. 5. Remove Bill C-7's provision allowing a disabled person's healthcare or personal care provider to be an eligible witness to that person's request for MAID. 6. Retain Bill C-14's mandatory 10-day waiting period requirement, as it currently stands, and the requirement for independent verification of all MAID requests by 2 witnesses. 7. In response to the prevalence of medical ableism, add language to Bill C-7 that will ensure that all discussions surrounding MAID are patient-led and not prematurely initiated by the physician. 8. Remove Bill C-7's provisions waiving Bill C-14's important and necessary final consent requirements. Bill C-7 will enshrine a lethal form of ableism into Canadian law by making medical assistance in dying a legally sanctioned substitute for the provision of community-based supports to assist people with disabilities to live. The Council of Canadians with Disabilities, along with the entire disability rights community in Canada, is therefore pleading with policymakers to rethink and revise Bill C-7 in light of the reality of systemic ableism. You must ensure that MAID does not weaponize systemic ableism in Canada.
Thank you. Thank you. Thank you, Dr. Jans. We'll now go for the remainder of 1 minute to Taylor Hayat. Please go ahead for your 1 minute.
One domain where we're particularly concerned ableism will appear is in the medical system. I'd like to give you an example of what that looks like. Nearly 3 years ago, in January 2018, I became ill with a bad flu. I went to a walk-in clinic and was sent home with the usual advice: rest, Advil, and chicken soup. Contrary to what I was told to expect, my condition worsened and I began to struggle to breathe a few days later. I called the Ontario telehealth line and was advised to go to the ER. I called a few friends hoping to get a ride there, but no one could be with me until the next day. I took a cab to the hospital and was immediately admitted. A couple hours later, the doctor was no close to finding out what caused my illness. When she finally came to see me, she said, "The only thing we know is that this infection affects your breathing. You may need oxygen. Is that something you want?" My answer was, "Of course." She seemed surprised and unconvinced, though she asked again. My
Ms.
answer was
Hayat?
unchanged.
Ms. Hayat, my apologies. I'm just going to stop you here and ask for consent of the committee because we are over the 7.5 minutes that's allowed in my discretion. So I turn to the members of the committee to allow Ms. Hayat to finish her testimony. I'll see a thumbs up, please. Mr. Zuberi? Okay, all right, I see everybody. Please go ahead, Ms. Hayat. Thank you.
My answer was unchanged. I said, "Of course." In that moment, I would have been able to refuse treatment and permitted to die, or in a moment of weakness, bought into the stereotype that my life wasn't worth living and requested and received a lethal injection. Breathing supports would be considered standard treatment for a non-disabled person in my situation, especially somebody in their mid-20s as I was. That's supposed to be the prime of your life. All the doctor seemed to see, though, was a disabled woman, alone, sick, tired, and probably tired of living. This is nothing new. A study by Carol Gill of the University of Illinois at Chicago shows that doctors often perceive disabled people's quality of life to be significantly worse than disabled people's own views. Whether disabled or not, Canadians look to these professionals as guides. Doctors have power to shape others' perspectives, and they should wield it with great care. Both my age and the effects of my disability gave me an advantage. I was able to advocate for myself without support and be taken more seriously by non-disabled observers than many others would be. Yet this still happened to me well before the expansion was on the table. Here's how my story ends. I was diagnosed with pneumonia and thankfully never even needed the oxygen. I received antibiotics, came home after a week, and I'm here today. If this bill goes through, how many more disabled people at their lowest moments could have a drastically different and decidedly unwanted ending to their story? Thank you, everyone.
Thank you very much for that, Ms. Hayat. We'll now go into our first round of questions, starting with Madame Finley for 6 minutes. Please go ahead, Madame Finley.
Thank you very much, Madam Chair, and to all the witnesses. It's really quite humbling to be here with you today and hear your many stories. And my first question is for the council here today. Dr. Jantz, you talked about how we as a government and a society are aggressively pursuing one course of action through a pandemic lockdown to save lives, and at the other hand seem to be rushing through this legislation. And it's a great concern to me that we are doing so in a rushed way to expand the ability to end life instead of putting increased resources to support for living, and when it comes to it, palliative care. The government says they've consulted widely on this bill. So I'm wondering, from the perspective of the Council of Canadians with Disabilities, do you believe this consultation was extensive enough? And does it address the concerns of Canadians with disabilities?
Thank you for the question. I believe the consultation was. I believe that the consultation was moderately extensive. However, I believe that the government, that the consultation, was geared 2 words.
A predetermined outcome.
A predetermined outcome. That is evident by the
type of question.
By the type of questions that were asked in the online survey.
Thank you.
That seemed to be assuming that MAID would be expanded.
Thank you. Thank you, Doctor. Dr. Frazee, you have previously raised concerns about severely disabled people not being able to access the care they need. And I'm mindful that we've heard testimony that 70% of Canadians don't have access to palliative care. We've also heard testimony on what was called an inadequate patchwork of support this morning. Do you feel this bill addresses that? And do you agree that MAID should only be available as a very last resort, as it is in many other countries? In other words, only once every other treatment option has been exercised.
Yes, to answer your second, Madam Chair, if I may speak to the question of your member. Yes, absolutely. MAID should be an intervention of last resort, but only when a person's natural death is reasonably foreseeable. And absolutely, I agree, and I think all of the evidence points to the reality that there are far, far too many Canadians with disabilities and disabling conditions who have no access not only to palliative care, but to an array of in-home supports that would permit us to continue to live autonomously, to be the captains of our own ships, as it were, to be included and participating in the communities in which we are able to thrive. So all of these things are being deprived of disabled Canadians, and as a result, I think we have begun to see a real trend toward seeking MAID, yes, as a choice of last resort, but a choice among two choices, either to continue to live in deprivation or to die. And I think that is the essence of what members of the disability community are trying to convey here, that that's insufficient choice to support a robust account of autonomy.
Thank you. This question is for Mr. Rakako, if I'm pronouncing your name properly. I hope so. As a lawyer myself and a former litigator, I have a great concern that this matter was not appealed from the Quebec Superior Court and that the mandated review simply didn't take place before we now have before us expanded bill. Do you think it should have been appealed to the Supreme Court of Canada?
Yes, it should. And maybe it's not over yet. Maybe as some earlier participants mentioned, there's always a possibility to refer C7 to the Supreme Court of Canada directly. But more importantly, I think that C7 goes much beyond what is required to comply with the Truchon decision. It takes away or dilutes many of the safeguards that
Mr.
are already.
Rakiko, my apologies, but we're very much out of time, and I'm very cognizant. Thank you. I hope that this will come out in later testimony. We'll now move on to Mr. Kellaway for 6 minutes. Go ahead, Mr. Kellaway.
Thank you, Madam Chair, and I'll be sharing my time with MP Pawlowski. That's okay?
Yeah.
Okay, wonderful. I have a question for Dr. Frazee. First, I guess my first question is, what part of Mi'kma'ki are you from, or or you're calling from today? I'm just curious.
I'm in, Madam Chair, if I may respond, I'm in Kings County, Nova Scotia.
The reason why I ask is that I'm calling from Cape Breton, so it's the absolute maritime thing to do to ask where you're from. So I appreciate your response to that. Dr. Frazee, as you may be aware, Minister Lametti and officials held consultations with a number of stakeholders before informing Bill C7 rather. And these roundtables were issue specific. There were with ministers and parliamentary secretaries and officials, and there were extensive consultation with disability advocates. But I'm wondering, can you tell us what you know about these consultations and what were your impressions of them?
Yes, okay. Madam Chair, if I may speak to the question, I was fortunate to participate directly in those consultations. And I think Dr. Jantz has already suggested and indicated that there was very much a predetermined outcome. Given that we were extremely nervous about that predetermined outcome, we invited members of the Vulnerable Person Standard community to submit duplicate copies of their questionnaire submissions to us so that we could tabulate what we called the voices from the margins. And I would point to, and I can submit to the committee separately, the report that we compiled. Essentially, an overwhelming degree of concern and alarm at the direction that Bill C7 was heading with the removal of the reasonable foreseeability of natural death requirement. I would simply, given the limits of time here, say that it's not a popularity contest. It's not a question for polling when you are considering whether or not to respect the human rights of part of your population. Of course, we were in a minority. We are a minority, a significant minority of Canadians, but a minority nevertheless. And I think our voices need to be given particular attention. And they are in no way reflected in Bill C7.
Thank you so much. Madam Chair, how much time do I have in my 3 minutes?
You're at 3 minutes right now.
Okay, thank you very much.
Thank you. Mr. Pawlowski, you have 3 minutes. Go ahead, sir.
Yeah, I understand that the disabled are on good grounds concerned about removing the reasonable foreseeability of death criterion. However, I would say it wasn't the government that decided to do this. It was the Truchon decision. And as I've heard other people have said, basically the reasonable foreseeability criterion is off the table, and that the court with the Truchon decision took it off the table, and our government felt that the Supreme Court would only uphold the Truchon decision. So that's one problem. The other problem is, and although I agree with almost everything I've heard from the disabled, there are people out there who insist on, and I've spoken to a lot of people who feel that it's very important to them to be able to make such a fundamental choice should it arise for them. Now, this legislation is here. It's before us. The Truchon decision was made. Is there not, in your opinion, any way that we could amend the proposal to make it more acceptable to you? There's certainly a lot of safeguards in there, including 3.1G, which says requires a medical practitioner or nurse to ensure that the person has been informed of the means available to relieve their suffering, including where appropriate counseling services, mental health, disability support services, community services, and palliative care that has been offered, consultations with relevant professionals who provide those services or that care. So there is a requirement in there to tell people who might be contemplating using MAID of alternatives that would make their life better. Could we not amend what's here? Do you have any suggestions, or is the only way we can deal with this is to appeal the Truchon decision or use the notwithstanding clause? Anybody wanting to take it on?
Madam Chair, I'm not a lawyer, but I will say that the legal advice that we've had is that it is perhaps unprecedented for the Government of Canada to amend the criminal code on the basis of a lower court decision. So I'm not sure that I would agree, or that the people who have advised me would agree. And in response to the core question, I would say that you cannot tinker at the edges of a fundamentally norm-shattering piece of legislation. I'm sorry to say that.
Thank you, Dr. Frazee. And before I go to Monsieur Thériault, it's my oversight. We didn't go to Living with Dignity. Michel Rakiko for 5 minutes as a witness. Monsieur Rakiko, please go ahead. You have 5 minutes for your testimony.
Thank you, Madam Chair. As a lawyer and a former president of Living with Dignity, I'd like to thank you for this opportunity to share some comments with you. I'll be very brief because everything else is in our brief. Living with Dignity was founded in 2010. And since then, our citizens network of over 5,000 allies has been following very closely all the developments in end-of-life care in Canada and in Quebec. We've been present at every level and all the stages, including during the Lamartine cases. Unfortunately, since the implementation of these provisions in Quebec in 2015 and the rest of Canada in 2016, we've seen an expansion and a broadening of the safeguard measures, either through courts' interpretations or through practitioners of medical assistance in dying. We understand that the Canadian government has to now amend the legislation, but C7 is going far beyond what's required by introducing several amendments to safeguarding, and those safeguards had been deemed necessary in June of 2016. So we are asking that those safeguards be maintained for all people who are at end of life. We feel that this is very dangerous and hasty to act now during a pandemic when there has been no analysis of the current safeguard provisions during the parliamentary review, which should begin soon. In terms of the provisions for people who are not at end of life, we heard the message from the entire community of persons with disability and all of their advocacy groups. They raised the same issue about C14 when the Senate had proposed the removal of the end-of-life criterion. And they have been largely ignored in this proposal of amendments. We don't understand how the federal government could, on the one hand, adopt proposed measures which would make Canada the most permissive country in the world in this area, while making all kinds of wonderful statements of principle in the preamble to C7, as was done in the preamble of C14. And given some of the court decisions, which essentially reverse the conscientious objection of caregivers, it's desirable to have current provisions strengthened so as they state clearly that nothing in this legislation can force anybody not only to practice medical assistance in dying or to assist somebody, but you can't force anybody to refer an individual asking for medical assistance in dying to a colleague who practices MAID. Thank you.
Monsieur Rakiko. We'll go on to Monsieur Thériault for 6 minutes. Go ahead, please.
Mr. Thériault.
Madame la Présidente.
Thank you, Madam Chair. First, I would like to tell all witnesses that I really understand what they're advocating. They're advocating for better care, and it's absolutely essential to continue demanding that because, as I said, a handicap should never be a disability. It's the disability that is social. So I'm very I really understand what you're saying and what you're fighting for. And Mr. Racicot, I really like the name of your organization, Live with Dignity. We have to define the terms we are using, and to go quickly because I only have 6 minutes. Live with dignity, it means that you have to have the capacity to have freedom of choice. You have to be able to have self-determination when you have to make a decision, and particularly in a medical setting, never to violate the free and informed consent principle. So on the basis of that, I see two maybe difficulties with your brief. In the conclusion, when you say that the process, as other processes that give the impression that dignity is only based of autonomy, and by giving maid to the person, the dignity would be respected without taking into account the autonomy. So it means that to die with dignity, you should die earlier. And that is very sad. Yes, it is very sad. But the problem is that the court, for exactly the same reasons, declared that C-14 was not valid, because for the court it meant that the person had to end his or her life before reaching a certain threshold. So this was violating the right to life of that person. That was under C-14. But we should specify here that autonomy does not mean physical autonomy. This is only a condition that favors moral autonomy, or, for example, intellectual autonomy, because if you don't have the cognitive faculties, you're not able to give a free and informed consent. But you'll agree with me that physical disability has nothing to do with autonomy. What we are defending here with this bill, you agree with me on that? You are not thinking that, I hope. No, but I do not agree with you.
Les conditions
We mustn't simply look at the conditions in which people exercise their autonomy. First of all, we must ensure that our society gives them proper conditions for life, to live. I don't know if you're aware of the situation, but I've accompanied a lot of people at the end of their lives. I accompanied a lot of people to the end of their lives, including my own wife. And what I saw in my practice is that when we take care of people, when we accompany them, they want to live. They don't want to die. But those people, and I'm thinking of Martin Lauzon, who has left us. Mr. Lauzon had to fight for months to get a wheelchair, that was voice activated. It was easier for him, it would have been easier for him, to ask for a maid instead of appropriate services. And that's what people who suffer from degenerative diseases or deficiencies tell us. Remember that in Quebec, please let me finish. That's not what Sue Rodriguez or Ms. Carter or Ms. Taylor or Ms. Gladue or Mr. Truchon said. I understand your personal experience, and I agree with you. I said it at the outset. We must be able to improve the conditions and the care given to people who suffer from physical disability. That's not what we're discussing here. But in this bill, we're talking about removing or lessening some safeguards, even for people at the end of their life. So we'll have to review the act. But indeed, precisely because people in a terminal state are suffering pointlessly, even if they have access to optimal palliative care. It is indeed possible, when we're talking about palliative care, that the care itself brings about a situation of suffering. And I could give you all sorts of statements by witnesses in this regard. The idea isn't to make people suffer. Thank you, Mr. Theriault and Mr. Racicot.
Going to move on now to Mr. Garrison for 6 minutes. Please go ahead, Mr. Garrison.
Thank you very much, Madam Chair. I want to start again by thanking the witnesses and paying tribute to the people from the disability community and their advocates. No change for disadvantaged groups ever comes without the very hard work and very principled stands taken by those people from their own community and from their advocates. Of course, it's still my hope that these broader issues that are being raised will be dealt with in the statutory review of MAID legislation, because I think they have implications far beyond the narrow focus of Bill C7. That said, I have a couple of specific questions. So my first question is to Monsieur Racicot. Given that medical services are quite often limited in rural and remote communities, the question of referrals becomes a question of access to services for many Canadians. So you were very clear that you believe that the duty to refer should not apply in the case of medical assistance in dying. Is that a consistent opinion you share for all medical services, or is this specific to medical assistance in dying? In other words, based on their beliefs, physicians refuse to refer in other areas, or is this specific to medical assistance in dying?
Let me first say that once a person demands a particular medical treatment, a physician in his own professionalism is not forced to provide that service. He will seek the service that is most appropriate to the patient. Now, as to the referral, I understand that the situation in rural areas may be difficult, but it is not necessary for a particular practitioner who objects for conscience reasons to refer to somebody who doesn't share that objection. There are other means of making these referral services available to the population across a province. You just have to put in, an appropriate information system in place and do it.
My question was very specifically whether you believe the conscience right to refuse referrals applies to other medical services or practices other than medical assistance in dying.
Absolutely, absolutely.
Thank you very much, Mr. Racicot. My next question is to Dr. Jans. In your presentation, you went very quickly through some recommendations about C7. And what I believe you said was you oppose removing the waiver of final consent, you oppose eliminating the 10-day waiting period, and that you oppose reducing the number of witnesses. So I'd like to ask whether you believe that those provisions provide particular risk to members of the disabled community, or whether you simply oppose those in general.
Thank you for the question.
Thank you for the question. I believe that those elements
of the bill
pose a particular risk to people with disabilities,
given the reality of
medical ableism and the potential that people with disabilities, upon hearing repeatedly that they should want to hasten their death, would then succumb to to that message.
Okay, thank you very much. If I could ask the same question to Dr. Frazee, do you think that the provisions regarding witnesses, the 10-day waiting period, and the waiver of final consent pose specific risks for people from the disability community? Should they qualify for medical assistance in dying under the very high standard that remains in place?
Madam Chair, if I may respond to that, I have to respond first with this question. Am I assuming, for purposes of responding, that we now have medical assistance in dying for people who are not at the end of their lives? Is that implied by the question?
Certainly, Bill C7 says for those practices we're talking about, those whose death is reasonably foreseeable. So those provisions specifically relate to what's sometimes called the first track.
Okay. All right. So thank you. So that has not been the principal focus of my preparation, but I think it is important to recognize, as Dr. Jones alluded, the very subtle ways in which our messaging, even the delivery of our care, at times can nudge a person. You know, the best example I can offer is one that was given to me by a colleague in human rights who was describing racism, and he said, it's like a hair that brushes your cheek. Other people can't see it, but you can feel it, and you know exactly where it is. People with disabilities feel ableism in very much the same way in how we are regarded. And so in a weak moment, and we have to remember that the Carter decision, the original decision, described the risk of persons being vulnerable to inducement to seek, in a moment of weakness, to seek a route to end their lives. And so I think that those safeguards are in large measure there to ensure, or at least to help people get past those weak moments where we are at rock bottom. Sorry.
Thank you. Thank you very much, Dr. Frazee and Mr. Garrison. That concludes your 6 minutes of questioning. I see that we are at 1 p.m. Do I have the consent of the committee to go for a second round of questions? Yes. Okay. So thank you with that. Mr. Lewis, you have 5 minutes starting now. Thank you.
Thank you, Madam Chair, and thank you to the committee. We certainly appreciate this time. To all the witnesses, each of your stories were incredibly compelling today, and they're obviously vital to this conversation. So thank you very much. You know, it is a little disappointing that this legislation isn't getting the due attention that I believe that it deserves. I'd like to have 40 witnesses, 40 meetings to call witnesses, not 4. But just point of interest. First question, Madam Chair, is to Dr. Gallagher. Are you concerned, sir, about the removal of the 10-day reflection period? And if so, would you like this committee to consider a shorter time rather than see it abolished?
I would say I'm very concerned about the removal of the 10-day waiting period. It strikes me that this is such a serious decision to be made with such care and consultation, and with the assurance that all of the underlying issues that drive people to seek death, and those issues are well documented in the literature, in the palliative care literature, that all of those issues have been thoroughly addressed. MAID should always be seen as an option of last resort. The goal of healthcare is to help the patient to flourish, and palliative care is about helping the patients flourish even as they go through the dying process. So anything that accelerates or hastens that process and doesn't give the opportunity for reflection and so on, I think is of serious concern.
Thank you, Doctor. And through you, Madam Chair, again to Dr. Gallagher, can you explain how Canadians can access MAID without effective referral and why that's important for providers? And further, what provinces require effective referral in existing policy, and what have other provinces done to better balance conscious rates and access?
So Ontario and I believe Nova Scotia are the only jurisdictions in the world that require an effective referral. And in every other jurisdiction in Canada and around the world, patients are able to obtain access without the requirement for an effective referral. And there are mechanisms already in Ontario where I practice where patients can already seek access to medical aid in dying without an effective referral. And so it's quite clear that systems can be constructed, as Mr. Rasico already suggested, through telehealth, et cetera, and organizations representing healthcare conscientious objectors have made very reasonable and constructive proposals in this regard. So if there was a will on the part of the federal government, there's undoubtedly a way that this could be done so that we would not be required to aid and abet the euthanasia of our patients.
Thank you very much, Doctor. Madam Chair, through you to Madam Hyatt. Thank you very much for sharing your moving story of how a doctor in the hospital presumed you might want to die from your pneumonia because of your disability. We have heard heartbreaking testimony that this type of coercion can be subtle, but it is indeed common. What protections would you support to ensure that MAID participation is only voluntary participation through the whole process?
Most of all, I'd love to see an amendment put in place ensuring that discussions about medical assistance to end one's life, they're only raised by the person who wants to die. I would never want a medical professional to begin the conversation about life-ending initiatives as a result of assumptions they make about what it's like to live with my disability. Otherwise, I would not feel comfortable seeking certain forms of medical treatment. I want to be seen by a doctor who will care for me as a whole person, including taking my status as a disabled woman into account, and who will support me in living and thriving in the only life I have, which is as a disabled woman. Thank you.
Thank you very much. Do I have about, I'm sorry, Madam Chair, can you show me that again? 30 seconds. I'll go very, very quickly to Mr. Rasico. Should MAID be considered a therapeutic option equal to current standards of medical care? Thank you.
Very briefly, sir.
I'm not a doctor, so it's very difficult for me to say so, but certainly we do not consider MAID to be a medical care. Killing a person is never a care. So this is why it needed an amendment to the criminal code to allow that across Canada. We have fought in Quebec against Bill 52, saying that it was not under provincial jurisdiction, but that it fell under the exclusive federal jurisdiction over criminal law. So certainly MAID is not, in our opinion, a health care.
Thank you.
Thank you, Madam Chair.
Thanks, Mr. Lewis. We'll now move on to Mr. Virani for 5 minutes. Go ahead, Mr. Virani.
Thank you very much, Madam Chair. So just a lot of discussion has been had about the consultations that take place, and as somebody who participated in them, I think it's important that the committee testimony reflect that there were 125 experts and stakeholders that were met with in a series of roundtables that took place around the country with ministers and various parliamentary secretaries. There's also 300,000 people that submitted feedback via questionnaire. I also think it's important to just put on the record that the testimony we've heard today is very, very important. It's very critical, and the advocacy is being heard and being listened to. That the statements that have been put into the record in the chamber and including at the committee should reflect, as we all do as parliamentarians, that all lives are valuable, particularly the lives of persons with disabilities. And what we need to reflect also is that pressure is never appropriate in terms of any sort of coerced choice. And if there's ever pressure that is untoward, that it needs to be investigated and indeed prosecuted if that's necessary. I will ask a question to Dr. Gallagher, and then I'll ask a question to Dr. Rasico. So, Dr. Gallagher, you indicated, I think the term you used was aiding and abetting a death. And just to reiterate that there are actually 4 protections with respect to conscience rights that are found in both the preamble, the text of section of the old Bill C-14, the sixth to last paragraph, if I remember correctly, of the Carter decision and in Section 2 of the Charter of Rights and Freedoms. And the effective referral regime was actually litigated in Ontario to the Ontario Court of Appeal and was found to be constitutional. But I'm going to ask you to comment on another aspect, because you also mentioned the equality rights of persons with disabilities. And it's an important point. But I found another paragraph here where this actual issue was put to the court in Truchon, and the Truchon court found that by not changing the regime, the equality rights of persons with disabilities would be compromised, and Section 15 would thereby be violated. And the quote is from paragraph 678, and it says, the requirement at issue reveals a legislative regime within which suffering takes a backseat to the temporal connection with death. Where natural death is not reasonably foreseeable, the consent and suffering of the disabled are worthy only of the sympathy of Parliament, which has adopted a protectionist policy towards every such person, regardless of his or her personal situation. However, as soon as death approaches, the state is prepared to recognize the right to autonomy. This is a flagrant contradiction of the fundamental principles concerning respect for the autonomy of competent people. And it is this unequal recognition of the right to autonomy and dignity that is discriminatory in this case. So there's no doubt that discrimination is a live issue in this context, but in fact, the conclusion of the Truchon court was exactly the opposite to some of what we've heard today. I was just wondering if you could comment on that, Dr. Gallagher.
Sure, I'd be happy to comment. Thank you, sir, for the question. I'm not a lawyer, so I can't comment on the integrity and validity of the legal reasoning involved. But I will say in general, with respect to both the Superior Court decision in Ontario about the effective referral regime, as well as the Truchon Gladue decision, that the mere fact that a judge reached a decision does not imply that that decision was correct. And therefore, I don't think we can simply argue on the basis of the fact that the judge reached the decision that these concerns being raised are invalid.
Maybe if I could just chime in.
Is this Mr. Rasco? Mr.
Yes.
Rasco, if I could just ask you one other question, you could answer both. Mr. Rasco, you said in your submissions that, and I believe the quote was, Canada is looking like the most permissive regime in the world. And I was just wondering if I was giving you an opportunity to correct the record. I believe you're probably aware as a lawyer that the Benelux nations allow for medical assistance in dying for minors, and as well for situations where mental illness is a sole underlying condition. Neither of those two apply under C14, nor would they apply under C7. So perhaps if you want to clarify the record in that regard, and if you want to comment on paragraph 678 of the Truchon decision. Thank you.
Okay. First of all, when I talk about the most permissive regime, if you take the example of Holland, in Holland, there is a requirement not only that some of the treatments be available as it is in C7, but also that everything has been tried, and this is not present in C7. Secondly, on the other issue, I should say that the reasoning of the court, and I'm not saying we're trying to appeal it, but the reasoning of the court was focused on ignoring two of the objectives of the law, which are still present in C7, the inherent dignity and equality of each human life, and that suicide is an important problem. What the court said, and I have the French version, is she said that she could not recognize the first two objectives in affirming the value because these objectives were stipulated in a manner which was too vague. So she chose to ignore that, and she chose to consider, as the court did in Carter, that the only objective of C14 was to protect persons who could succumb to MAID in a moment of vulnerability. So I think that
Thank you, Mr.
we need to
Rasco.
take a look back at that decision.
Thank you. I appreciate that. Thank you, Mr. Varani. We're now going to move on to Monsieur Theriault for 2.5 minutes. Go ahead, Monsieur Theriault.
Oui,
Mr. Rasiko, you've just mentioned that medical assistance in dying is not an end-of-life care principle in your mind. In Quebec law, this is part of a continuum of care. So the request for dying that comes from the wish, will, and desire of a patient whose death is irreversible and whose process of dying has already begun. When this happens, It should happen in a situation of palliative care, total and complete palliative care. Cecilia Sanders, Elizabeth Kubler-Ross, palliative care is accompanying somebody towards death, comprehensive, the psychological and physical assistance with pain. And it happens that in palliative care, a patient does better. Palliative care can, in fact, slow down the death process, even if it's irreversible, and it can cause adverse effects, sometimes related to medication which were taken against pain. So a patient's request to die in a context of overall complete palliative care, you think this is not an end-of-life care situation? I consider that's not care. It's not care, according to medical terms and legal definition of the term. In Bill 52, the Medical Act had to be changed. It had to be amended to say that giving a patient something that will bring on death had become a medical act. It hadn't been one before. If you look at all of Quebec's legislation discussing health care, you will see that it talks about relieving, but even the definition of the World Health Organization, in no case is palliative care construed as an act to provoke death. But Mr. Lesko, palliative care doesn't mean let somebody die. It means providing care, and in relieving pain, there could be a last dose which will be fatal. So it's not true to say that palliative care does not cause death. It will ultimately cause death. You know that very well. An individual who is serene, at peace, and ready to leave, it would seem that we should hope that everybody could have this on their deathbed, to be properly accompanied and to feel serene. And I hope that you will have that opportunity.
Don't have that time. Thank you, Monsieur Theriault. Mr. Garrison, for 2.5 minutes, sir. Please go ahead.
Thank you very much, Madam Chair. Could you just clarify when this session will be ending, as we are considerably over and we may have to make some other arrangements?
So it's after you. We have 10 more minutes, and that's all.
Thank you very much, Madam Chair. Given that we're drawing to a close here, I'd like to give my last time here to Dr. Dr. Jans, to having heard the questions, having heard the presentations here today, to make any final comments she would like to make to the committee.
Thank you.
Thank you. I think any civil society is based on a delicate balance. This is right on one end. Based on the rights on one end. And my individual rights on one hand. Individual rights on one hand. And social responsibility on the other hand. We've seen from our neighbors in the south. We have seen from our neighbors in the south what happens when individual rights. What happens when individual rights take precedence over social. Take precedence over social responsibility. A lot of people die needlessly. Do we as a country want to take that approach to make life or because that is what Bill C-7 currently does. It makes us into the U.S. Thank you.
Sorry, Mr. Garrison, that is all the time you have. We'll go now to Mr. Moore for 5 minutes. Go ahead, Mr. Moore.
Thank you, Madam Chair, and thank you again to all the witnesses. Very informed and relevant testimony today. Raises grave concerns with me about the sufficiency of the amount of time that the government has put forward to deal with this legislation. I feel that we should be having more meetings of this committee because we're hearing new perspectives now that we haven't heard in previous testimony. It's been put out there that there's been some kind of unanimity and great support amongst the medical community. But Dr. Frazee, we've seen a letter signed by almost 800 doctors who have expressed serious concerns about how Bill C-7 opens up the medical assistance in dying regime in Canada. And I want you to comment specifically on something. Bill C-14 had a number of safeguards in it. After the Truchon decision, the government responded with Bill C-7, but in doing so, they have stripped out a number of safeguards that they didn't have to. The 10-day reflection period, the requirement that there be two witnesses, things that could provide an element of a safeguard for those that are engaged in this process. I'd like your comments on that, because I think it's greatly troubling when we see safeguards that were put in place very recently, and then at the first instance, we're stripping them away.
Thank you, Madam Chair. If I may respond to the member's question. Yes, absolutely. I think we have been actively documenting, and we can provide, I think, ample evidence. It is anecdotal evidence, cases that come to our attention through the mainstream press and on social media, of instances where even with the universally applied requirement and the most fundamental safeguard of reasonably foreseeable natural death, even with that safeguard, we see adverse impact on people with disabilities. This raises human rights concern, as it did, as Dr. Jantz mentioned, to the special rapporteur from the UN on the implementation of the Convention on the Rights of Persons with Disabilities. We know there are problems with the existing law, and we also understand that there is a review of that law scheduled at some point in the future, at which point I think we would advocate for much more rigorous and independent monitoring of the current practice of medical assistance in dying, to ensure that it is applied and that its effects are equally felt and equally autonomy promoting. At such a time, it seems really alarming to us, more than alarming, fundamentally wrong, to be removing safeguards, the most critical of which, as I've already said, is the requirement that you be at the end of your life.
Dr. Frazee, we heard in prior testimony today from Krista Carr with Inclusion Canada, and she described this situation now as the worst nightmare. So that's pretty strong language for those persons with disabilities. What is it that the government's missing here in what I think is an overreach in this response? Our position was that this should have been appealed. It's a lower court decision in Quebec. It should have been appealed, and that when you have a brand new bill like C-14 was, it's the government's responsibility to defend its legislation. And at the first instance, it gave up on its own legislation and the safeguards that were in it. So if you could speak to why this would be described as a worst nightmare for those persons with disabilities.
Yes, Madam Chair, if I may respond in 30 seconds or less. Absolutely. The delicate balance between autonomy and equality that was struck in Bill C-14, if Bill C-7 proceeds, that delicate balance is, it simply no longer exists. It is a nightmare scenario, both in terms of the message it will send and the immediate consequences. Sorry.
Thank you. Thank you very much for that, Dr. Frazee. We'll now go on to Dr. Pawlowski for 5 minutes. Go ahead, sir.
Thank you. Let me start off by saying I'm not by my name.
Je dirais que de nature, je suis pas très enthousiaste. Désolé.
Translation in French while I'm speaking.
Sorry, it's okay.
You're good.
Okay, let me start over. I am by my nature someone who's not overly enthusiastic about MAID, having spent 35 years trying to do the opposite, provide people with life. That's certainly one of the reasons. But having worked a lot in developing countries, it seems to me questionably ethical that we're putting all this money into helping people to die here when so many people around the world, but for a few dollars, die in other places. So now, having said that, C7 was drafted after extensive consultation, including with the disabled, but specifically on the question of removing the reasonably foreseeability of death criterion from the law. We've heard a lot of people today who are against that, but to those people I ask, what do you say to somebody who has a high spinal cord injury and ends up quadriplegic at a young age? Dr. Gallagher is a fellow emergency room doctor. I'm sure you've seen some horrible injuries, burns, disfiguring injuries. I certainly hope that all those people manage, and we've seen them, at least with the specific injury, and we certainly hope that their life remains worth living. But for some people, that may not be the case. Even though we provide them with all the assistance we can, they still decide that they don't want to live that life with those disabilities. Now, if God forbid that this happened to any of my 6 kids, and certainly if it did, I would do my best to make their life worth living. But at some point, should they decide they don't want to live and you love them, shouldn't we be giving them the opportunity should they wish to end it? And so what is your proposal then? Should those people not be given the option? I throw that to anyone out there.
Sure, I'll be happy to address that. Thank you, Dr. Pawlowski. So there is no question that these patients may suffer greatly, but the thing that never fails to amaze me is the resilience of the human spirit. And I have seen many patients with spinal cord injury. And one of the things that is well documented in the literature, and as other witnesses have already said, is that we often and nearly always profoundly underestimate the extent to which those patients value their lives and value their persons. And I've presented reasons why I would not be willing to participate in ending the life of a patient in that condition, because it'd be treating them as a means to an end. Now, it is a free society, and some doctors are willing to do this. But if you're going to put this law in place, then it needs to guarantee that someone like one of your children, in the terrible scenario that we all fear that you presented, ensures that they have all of the potentially reversible determinants of suicidality addressed, that they have the companion, the patient that I spoke of, who is just deeply, profoundly lonely and isolated, and that we ensure that those kinds of needs and concerns are addressed. And this law needs to guarantee that those processes, the infrastructure is in place to meet patients' needs before they arrive at a position where they feel like they have no option left but to seek euthanasia.
Does anyone else want to address the question I asked?
One thing that is important is to allow people sufficient time to adapt to their new incapacity, to their new disability. And most often, and the evidence that was presented by the federal government in the Truchon case showed that people, once they have adapted to their new situation, find a meaning to their life, and even to the extent of finding much more meaning than people who are not disabled. So the literature supports that as well. as I'm sure you know as physicians. So we need time, and the 90-day period is not sufficient to adapt to this new situation when you cannot even get a treatment in 90 days.
You have 10 seconds.
Madam Chair, perhaps I saw Dr. Hans had her hand up, and I also have...
My sincerest apologies. I understand the time limitations. If you, I would appreciate that. If there are any questions that need further clarification by witnesses, please do submit them in writing to the committee through the clerk. We'd appreciate that. And with that, having exhausted our 2 rounds of questioning, I would like to thank our witnesses for your time today. And I will clarify, based on some of the testimony presented by witnesses, that we have established how much time is given for witnesses to be able to make their presentations as a committee. And we did try to accommodate based on however much we could. But I really do thank you for taking that time and for working within the confines of our Justice Committee. Thank you. And then just very quickly to the members, 2 quick points. Firstly, the amendments or any proposed amendments that you have are due by Friday the 13th by 4 p.m. Please note that if you would like some assistance in drafting amendments, please get in touch with the legislative clerk if you have any questions that they can answer. And then the last thing is that we do have 1 open slot for this coming Thursday, based on just how the witness list ended up landing. And if I have the consent of the committee, we have a written request by the Nurses Association of Canada to be invited. And so if I have your consent, we'll go ahead and provide that invitation to them to come in. Yes, I see nodding. Do I have the, just give me a thumbs up so I can see it. Mr. Moore? Okay, wonderful. Ms. Finley, perfect. All right, with that then, I thank you once again for a wonderful
Point of order, Madam Chair.
Yes, of course, Mr. Moore, go ahead.
Yeah, and Madam Chair, in light of, you know, we've gone over again today by half an hour. The testimony we're hearing is so important. We're not hearing unanimity. We're hearing different sides. We're hearing people speak with compassion on both sides of what's a really important issue. I'm moving a motion that this committee would study this legislation for 2 more days, 2 more 2-hour sessions. So that we can hear more testimony and more witnesses. I think this is I recognize the government has a timeline it'd like to keep to. I'd like to see us be able to do that, but I really feel that to do our job properly, we do need to hear some more testimony. So I'm proposing a motion that we hear 2 more days of witness testimony.
Thank you for that, Mr. Moore. I'm just going to turn to Mr. Clerk. Given that we had passed a motion already on the timing, can I just come to you and seek clarification as to what the procedural impact of this motion would be?
Well, I would only suggest that maybe what Mr. Moore really meant is to add maybe a few words at the start of his motion, saying something like, notwithstanding the decision made by the committee on XYZ date, and then the rest of his motion. And that would make it like perfectly in order. Thank you.
Thank you. Thank you, Mr. Clerk. I see, Mr. Virani, you have your hand raised, and I do encourage members to use the blue hand raise function on the participants list. Go ahead, Mr. Virani.
Thank you. I appreciate the comments from Mr. Moore, and I also appreciate your work as chair to facilitate and use your discretion to ensure that we're hearing the testimony and providing accommodations, particularly to today's witnesses. Those are all important initiatives. But I also think it's important for the committee to respect the decision of the steering committee that was already made with respect to the procedure that this committee would follow. There's conservative representation at that steering committee meeting. Decisions were made, and I can't go into details about those because I believe those are...
Madame la Présidente, question de procédure. Là.
Madam Chair? A procedural question. There is no interpretation going through because Mr. Virani's sound has all of a sudden become very poor. Mr. Virani should speak louder and perhaps adjust his microphone.
Thank you.
I apologize, Monsieur Thériault. Monsieur Thériault, je regrette. C'était juste...
Apologies, Mr. Dello. I was having trouble with my microphone, says Mr. Virani.
Speaking English right now, but while I appreciate the intervention of Mr. Moore, I also appreciate, Madam Chair, your ability to stick handle today's meeting, providing accommodation to the witnesses where required, and using your discretion to ensure that we had enough time to get through this important testimony. But I do also believe it's important to stand by decisions that the committee has already taken, and I'm quite reticent to see decisions being revisited meeting after meeting with respect to decisions that have already been taken. There's already a decision made by the Steering Committee on Procedure. That's why it's constituted, so that we can have all parties come to an agreement as to how we will roll out a study on a given bill. We do have a court-imposed timeline on this bill. That's an important timeline. And we've had agreement, including with Conservative input, on how this bill would be structured and how this how many days would be devoted to the study and how many days would be devoted to clause by clause. Those are important decisions that have already been taken, and my view is that we should stick by those determinations. If we need to take a vote on Mr. Moore's impromptu motion today, then perhaps we should just take a vote on it. Thank you.
Thank you for that, Mr. Virani. I do have 3 more people on the speakers list. Obviously, I'm cognizant of time. If I can ask members to please keep your remarks as brief as possible so we can get through the day. Madam Finley, you're next.
Thank you, Madam Chair. Firstly, I would second that motion. And the committee structures are masters of their own fate. We can revisit anything. There was some confusion about what happened at the subcommittee to begin with, as I recall when we rolled it out at an earlier meeting. And although that decision was taken, there is nothing stopping us from revisiting any such decision. I am finding it very difficult with such an important bill to have the witnesses rushed so much as they are. There's not much time for good questions. If we are talking to any witness who may be a person with disabilities, we need to give them a little more time sometimes. This is not the way we should be dealing with such important legislation. And we would still well be within our time from the court. So I really urge the committee to consider this so that we are not seen by Canadians to be rushing such an important bill, that we give it the time it needs. Thank you.
Thank you, Madam Finley. Mr. Moore, I have you next on my list. Go ahead.
Yes, I mean, notwithstanding any discussions that took place at steering committee, when we see how rushed we've been with our witnesses, when we see the interest that there is in this bill, and when we start to hear the testimony, it's perfectly reasonable for us as a committee to say, you know what, we do need a couple more days. I'm not asking that that we add 10 days or anything like that, but I think 2 more days of witness testimony, the ability for members of parliament to ask questions that we're beginning to explore now. I'd asked the members of the committee to consider that in spite of all the things that we're hearing, we only have 1 more day scheduled to hear witnesses. And really, we get in 1 round of questions. The witnesses present for a few minutes each, and the chair is doing her best to facilitate this within the time constraints that we have. But I think in light of that, we need a little more time, and I would suggest that we take 2 more days, and that is my motion.
Thank you. Mr. Moore, I see Mr. Cooper, and we've exhausted the list at that time, and then we'll go to a vote. Go ahead, Mr. Cooper.
Well, thank you very much, Madam Chair. And let me just say, as the Conservative who was at the subcommittee meeting, that at no time was it my position that 4 meetings followed by 2 meetings of clause by clause was adequate. And I think, based upon the testimony that we heard today, it's become clearer that in fact is the case, that it is insufficient and that more time is required. I know, having served on a special joint committee on physician-assisted dying and been on the Justice Committee with you, Madam Chair, during the study of Bill C-14, that there was a very thorough process that not only resulted in more meetings, but then longer panels. This is a very condensed process. It's one of the most complex areas that Parliament could possibly legislate. And I think Mr. Moore's motion to simply require an additional 2 meetings would provide an opportunity for this committee to do its due diligence without in any significant way running up against the clock that the government is concerned about. And again, with respect to that clock, the government wouldn't be in this situation had it chose not to prorogue Parliament. Thank you.
Thank you, Mr. Cooper. And just
could I just raise a point of order, Madam? And I'm literally asking you for clarification and from the clerk, because I, like Mr. Cooper, I believe joined Parliament in 2015, and I just am not aware of. I'm aware of the fact that when you have an in-camera meeting, the results of the meeting are made public, but not the deliberations, including the positions that were taken. And Mr. Cooper seems to have waived that confidentiality and just indicated his position at that meeting, and I just don't know whether that's appropriate. I certainly have never done it, and I'm just seeking clarification from you and from the clerk as to the propriety of that.
Well,
sorry, Mr. Cooper. Thank you. We'll just go to Mr. Clerk to just clarify on the rules of in-camera meetings, and if what Mr. Cooper has spoken about is violates those rules.
Madame la Présidente,
Madam Chair, what I could mention to the committee is that positive decisions coming from in-camera decisions, whether they're at subcommittee or plenary committee meetings, they are made public. But anything regarding the deliberations leading the committee to either pass a motion or not pass a motion remain confidential.
Mr. Clerk, and thank you for that point of order, Mr. Virani. We should at this time, I just would like to just hold this for 30 seconds while I just consult with the clerk on a couple of things. So I'll just suspend for 30 seconds. Thank you.
Je suis en faveur.
Mr. Garrison?
I vote against.
Mr. Kellaway?
Against.
Mr. Lewis?
I vote in favor.
Mr. Polowski?
Against.
Mr. Moore?
In favor.
Mr. Sangha?
Against.
Mr. Virani?
I vote against.
And finally, Mr. Zubiri?
Vote against.
So, Madam Chair, yeas pour 5, 5. Nays contre 6, 6.
And so the motion is defeated. Thank you very much, gentlemen and ladies. We shall re-adjourn at the next meeting. The meeting is now adjourned. Thank you.